So may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good evening and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as an allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as a digital partner for this online event hosted by the Cancer Kids Strength of Smiles Doctors Network Maharashtra chapter. And the focus of today's session is a webinar on extracranial germ cell tumors. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Monica Bhagat ma'am, a much sought after pediatric surgical oncologist and the founder of CKSOS and SRCC Children Hospital, Mumbai, to start the event today with her enlightening words and for the further coordination. Over to you, ma'am. Please proceed.
Can you please share screen? Can you please share the presentation that was shared with you, or should I do it?
Yes, ma'am, sharing.
Good evening. I welcome you all on our platform. Today we'll be talking about extracranial germ cell tumors, and we'll be covering approach to pediatric germ cell tumors, understanding the principles of management, surgical decisions, and the role in staging. And we'll be having a few interesting cases to discuss. Ritu, next slide, please. We have Dr. Prasanna Kumar, who is Associate Professor in St. John's Medical College. He'll be moderating the session. Over to you, Dr. Prasanna. Ritu, can you move to the next slide?
Thank you, Dr. Monica. Yeah, today we have a session on gonadal tumors, extracranial GCT. So we have top speakers coming this one. We have first speaker, Dr. Jyoti. She is an assistant professor from St. John's Hospital, and she has done her BM Pediatric Onco from Kidwell. She will be talking about on the approach to pediatric germ cell tumors, and then followed by.
Ritu, next slide.
Yeah, we have speaker Dr. Pablo Andres Lobos. He is the chairman of Division of Pediatric Surgery from the Italiano di Buenos Aires, Argentina. He is also secretary of International Society of Pediatric Surgical Oncology. He will be giving a talk on principles and surgical approach, extragonadal GCTs.
Ritu, next slide, please.
Yeah. And we have Madam Dr. Shushmita Bhatnagar. She is a senior consultant, pediatric surgical surgeon from Bombay Hospital, Mumbai. She is a chairperson and association pediatric surgery oncology, IAP. And ma'am will be giving surgical guidelines, gonadal germ cell tumors, talk on the gonadal germ cell tumors. Then we have a panelist, Dr. Anupurva Datta. She is Associate Professor Pathology from Homi Baba Cancer Institute, Visakhapatnam. Welcome, ma'am. Then we have Dr. Hiren Panawala, the Consultant Pediatric Radiology from NHSRCC Children's Hospital, Mumbai. I welcome everyone. Now we will start our session with Dr. Jyoti on overview on pediatric germ cell tumors.
Thank you, sir. So I'll begin with my presentation. Am I audible?
Yes, ma'am, you're audible.
Yeah. So this will be the layout of my presentation. I'll be dealing with the clinical presentation, diagnosis, risk stratification, and chemotherapy. So any malignant cancers of the germ cells in a child age 0 to 18 will be called a pediatric malignant germ cell tumor. And like we know, germ cell tumors can be both intracranial and extracranial. And in extracranial tumors, we classify them as gonadal and extragonadal tumors. So coming to the incidence of germ cell tumor, about 2.4 cases per million children per year is the annual incidence. About 3% of malignant tumors in children less than 15 years of age are germ cell tumors, while 15% of tumors in adolescents are germ cell tumors. So there are various risk factors for germ cell tumors. Cryptorchidism is a well-known risk factor for testicular tumor. It leads to a 10 times increased risk of developing seminoma in the undescendant testis if orchidopexy is delayed, and hence orchidopexy is suggested to be done within 2 years of birth, 2 years of age. Gonadal dysgenesis again is a known risk factor for germ cell tumors, especially in females. About 30% children with gonadal dysgenesis progress to develop germ cell tumors. And syndromes such as Swyer syndrome, which is a 46XY constitutional presentation with both internal and external organs being female, is again a risk factor for GCT, especially gonadoblastoma and dysgerminoma. And so is Turner syndrome, a risk factor for gonadoblastoma and dysgerminoma. Klinefelter syndrome. Especially young male children or adolescent males who present with mediastinal tumors, there is a 10 to 30% chance that they have Klinefelter syndrome. So these are the risk factors. And coming to the clinical presentation, as I show in this picture, germ cell tumors are known to have a very heterogeneous presentation. So the age at presentation, their location, histology, the malignant potential, genetics, treatment response, everything is variable. So I will deal with all of this one by one. Coming to age, there are 2 peaks of presentation for germ cell tumor. The first peak is children less than 5 years of age, and the second peak is adolescence or the onset of puberty. Children less than 5 years of age tend to have an extragonadal location, whereas the children who are adolescents tend to have a gonadal location of germ cell tumor. Also, the histology in these 2 age peaks tend to be different. Children less than 5 years tend to have a yolk sac tumor or a teratoma, as compared to adolescents who tend to have mixed malignant germ cell tumors or the non-germinomatous germ cell tumors. Coming to the malignant potential. So while teratomas are benign, immature teratomas have a tendency to locally recur, and malignant germ cell tumors are very aggressive with tendency for metastatic spread. Likewise, genetics in children less than 5 years of age is different from what we see in adolescents. The classical 12p amplification is seen in adolescents, while those younger than 5 years of age have an entirely different set of genetic changes. And treatment response, while germinomas, seminomas, or dysgerminomas are extremely chemo and radiosensitive, non-germinomatous tumors are less chemo and radiosensitive. So coming to age, I did mention that there are 2 age peaks. One is the first 5 years of age, and the second is adolescence. While the first image is that for extragonadal tumors, and the second is that for gonadal tumors. This data is obtained from the US cancer registries, assessing close to 600 children with germ cell tumor. I'd like to bring your attention to 2 important points. Firstly, we do know the green lines here are the male children and the blue lines are the female children. All sorts of germ cell tumors tend to be more common in males across age groups and across location. The only exception to this rule is extragonadal tumors in children less than 5 years of age, where females tend to have a higher incidence of germ cell tumors compared to males. The other point I'd like to draw your attention to is the incidence of gonadal tumors in children less than 5 years of age, pre-pubertal females. So while male children have an increased incidence of gonadal tumors in the first 5 years of life, female children do not have the same risk of developing germ cell tumors, especially if a child, pre-pubertal female, presents to us with an ovarian germ cell tumor, we do have to look for the possibility of dysgenetic gonads and therefore the need for karyotyping them. Location. We all know that germ cell tumors have a propensity to develop in the midline. while 50% of all tumors develop in the gonadal regions, extragonadal regions like head and neck, mediastinum, retroperitoneum, and sacrococcygeal area are the common extragonadal locations, and they constitute another 50% of all germ cell tumors. So coming to the histology, germ cell tumors can be divided into those which develop from germinal cells, that which develops from extraembryonic tissue, and from the embryonic tissue. If a tumor directly develops from the germ cells or the primordial germ cell, we call it a germinoma. If it is present in the ovary, it's called a dysgerminoma, and the same tumor in the testis is called a seminoma. Tumors arising from extraembryonic tissue are yolk sac tumor and choriocarcinoma, and those tumors which arise from the embryonic tissue are called embryonal carcinomas. A somatically differentiated embryonal tissue can give rise to a teratoma. Germ cell tumors are also classified based on their origin as type 1 germ cell tumors and type 2 germ cell tumors. So a PGC that I'm pointing towards here, which is a primordial germ cell, during embryogenesis migrates from the yolk sac, runs through the mesentery to reach the gonad. During its travel from the yolk sac to the gonad, it is called a migratory PGC. And once it reaches the gonad, it's called a gonadal PGC. If a tumor develops when the PGC is in its migratory state, they are called type 1 germ cell tumors. And because it is still in the process of migration, they tend to develop in extragonadal tissue. That is why, like I said previously, a child less than 5 years tends to have extragonadal tumor, and the histology is either yolk sac or teratoma. Once the PGC reaches the gonad, it can differentiate into seminoma and all other non-germinomatous germ cell tumors. Hence, an adolescent would tend to have a gonadal tumor of a mixed malignant GCT histology. The genetic changes in both type 1 and type 2 tumors are variable. One point I'd like to drive home is the amplification of 12p, which is not commonly seen in type 1 tumors which occur in children less than 5 years of age. Coming to the clinical features, we all know that the presentation of germ cell tumor is very heterogeneous. So how do we remember the patterns of presentation of germ cell tumor? To tickle your pictorial memory, I will present it this way. Mature and immature teratomas can present in the newborn period in the sacrococcygeal region, which is the most common site, and in the ovaries of pubescent girls. This is the most common presentation of mature and immature teratomas. Now, we have prepubertal boys and postpubertal boys. A prepubertal boy presenting with testicular enlargement, which is localized, is probably a teratoma or a yolk sac tumor, while a post-pubertal boy presenting with a testicular mass is probably a mixed malignant germ cell tumor, and unlike his prepubertal counterpart, has a higher incidence of metastatic disease. This is the typical presentation of malignant testicular germ cell tumor. A post-pubertal girl presents with an abdominal mass or pain abdomen, which are the most common presentations of an ovarian germ cell tumor. They can also present with an acute abdomen due to either torsion of the tumor or rupture of the tumor or ischemia or infarction of the tumor mass. This germinoma in this ovary is the most common presentation of a malignant ovarian GCT. Like I mentioned before, prepubertal girls, prepubertal girls, the incidence of ovarian GCT is very less. A young child presenting with a sacrococcygeal mass or An adolescent child presenting with a mediastinal mass is the most common presentation of an extragonadal germ cell tumor. The mediastinal masses in adolescents are very likely to be mixed malignant germ cells as compared to teratomas in younger children. So, having known the various clinical patterns of presentation of germ cell tumor, what do we do next? The first thing we'd like to do is local imaging with an ultrasound. The purpose of an ultrasound is to localize and characterize the tumor. The confirmation of the extent of disease can be obtained by a three-dimensional imaging such as CT scan. Baseline blood investigations are to follow next, which includes complete blood count and biochemistry, which assesses liver and renal functions. Also important is to perform tumor marker testing, which is alpha-fetoprotein, beta-HCG, and LDH, 3 tumor markers for germ cell tumor. To differentiate it from other tumors like neuroblastoma, or urinary BMA can also be sent. After local imaging, the next we do is local site morphology assessment, either by an excision biopsy or a core biopsy. After we assess local imaging and local morphology, we move to metastatic imaging and metastatic morphology. Metastatic imaging can involve non-contrast CT of the chest to look for lung mets, or abdominal CT to look for liver mets, which are the most common sites of metastasis in GCT. Bone scan is done only when the clinical condition is implicating the need for a bone scan, which would be bony pains, extensive metastatic disease, and a child with choriocarcinoma. The morphology for metastatic disease here would be a bone marrow aspiration and biopsy only if a child has unexplained cytopenia. So this would be our approach to diagnosis. Normally, biopsy is the most commonly performed testing, either excision or core, if NACT is planned for most tumors. But in a child with germ cell tumor, we can get away without doing a biopsy on the base, and a diagnosis can be established based on radiology and tumor markers. So if there is tumor marker elevation in a suspected tumor mass, it indicates the presence of either yolk sac elements or choriocarcinomatous elements, and hence obviates the need for a biopsy. An exception to this rule would be the presence of an intra-abdominal primary, which is abutting the liver and producing alpha-fetoprotein. In this case, it could also be a hepatoblastoma, and hence a biopsy becomes necessary despite elevated tumor markers. What are the imaging modalities of choice? A computerized tomography of the primary site is the most commonly employed method for looking at the extent of disease and for regional lymph node assessment. An MRI would be indicated if there is evidence of spinal cord compression, especially in mediastinal tumors or in sacrococcygeal or retroperitoneal tumors. A bone scan would be indicated if there are bony pains, if it is a choriocarcinoma, or a child with elevated ALP or extensive metastatic disease. An MRI of the brain would be clinically indicated if there is evidence of neurological focal deficits, or in a child who has an HCG which is greater than 10,000. There are 2 types of tumor markers which are commonly employed: alpha-fetoprotein and beta-HCG. LDH that is used in germ cell tumor is not a specific marker and is a non-essential marker. Alpha-fetoprotein indicates the presence of yolk sac tumor components, and a moderate elevation can also imply the presence of embryonal carcinoma elements. Beta-HCG would be elevated in the presence of a choriocarcinoma element, as also some embryonal carcinomas and germinomas. The half-life of alpha-fetoprotein is about a week, and the half-life of beta-HCG is 1 day. To look at the normal values of alpha-fetoprotein, particularly in children less than 2 years of age, the utility of a nomogram is well known. So how do we stage? different tumors, gonadal, gonadal and extragonadal tumors. The common system that we follow is the Children's Oncology Group staging system. This is the staging of ovarian tumors. We have stage 1, stage 2, stage 3, and stage 4. It is important to remember that apart from the degree of surgical resection, that is complete resection with microscopic residue, gross residue, and distant metastasis, classifying them as 1, 2, 3, and 4. We also need to look at 4 other aspects in staging an ovarian tumor. Number 1, the presence of retroperitoneal nodes. If any tumor is greater than 2 centimeters in size, it would qualify the diagnosis of a stage 3 ovarian tumor. Similarly, presence of malignant cells on peritoneal washings will again qualify a stage 3 ovarian tumor. If a half-life decline less than what is anticipated for a 7-day half-life of alpha-fetoprotein and 1-day half-life of beta-HCG is not seen, then it would qualify the diagnosis of a stage 2 ovarian tumor. And the presence of contiguous visceral involvement, that is omentum, intestine, or bladder, makes it a stage 3 ovarian tumor. Similarly, for the testis, surgical resection, a high inguinal orchidectomy is the treatment of choice. And if complete and the tumor is limited to the testis, it becomes stage 1. Presence of microscopic disease or a violation of the capsule makes it stage 2. A gross residue makes it stage 3. And presence of distant metastasis makes it stage 4. Apart from the surgical resection status, lymph node status and tumor markers are the 2 other important criteria which are required for staging testicular tumors. Again, a retroperitoneal node greater than 2 centimeters qualifies the diagnosis of stage 3, and an incomplete tumor marker decline as anticipated or an unsatisfactory tumor marker decline would qualify the diagnosis of a stage 2 testicular tumor. Extragonadal tumor staging, again, is similar to the other tumor stagings. A complete resection makes it stage 1. A microscopic residue makes it stage 2. Gross residue, regional lymph node involvement, or visceral or the peritoneal involvement of the visceral organs in the presence of an intra-abdominal extragonadal tumor also qualifies a diagnosis of stage 3, and distant metastasis makes it stage 4. So what about risk stratification? Numerous risk stratification methodologies have been employed in the past. For example, UK CCG study 2, the stratification was different from what was employed in group 3 study. COG risk stratification again was different. However, now after the MAGIC trial data, MAGIC consortium data has been reported in 2015, the MAGIC risk stratification has been become the standard of care. And the AGCT 0531 and 0532 studies are currently the only studies which have employed the MAGIC risk stratification for future trials. So what have we learned from the MAGIC data? MAGIC stands for Malignant Germ Cell International Consortium. Any tumor, whether gonadal or extragonadal, irrespective of age, if it is stage 1, it is a low risk tumor. A testicular tumor which is stage 4 with IGCC positive, I will get back to IGCC subsequently, an ovarian tumor which is stage 4, and an extragonadal tumor which is stage 3 and 4 in children who are greater than 11 years of age makes it a poor risk tumor. All other tumors are standard risk tumors. In standard risk again, we can classify them into standard risk 1 and standard risk 2. Standard risk 1 are all the children who are less than 11 years of age, that is testis, ovary, and extragonadal stage 2, 3, and 4. All children who are more than 11 years of age become standard risk 2. So all stage 1s are low risk. All children greater than 11 years of age with testis stage 4 and IGCC high risk, ovary 4 and extragonadal 3 and 4 qualify the diagnosis of a poor risk germ cell tumor. The IGCC is International Germ Cell Consensus Classification. This was proposed in 1997. However, it still does have relevance, especially in differentiating a stage 4 testicular tumor as standard risk and high risk. Any child who is more than 11 years of age with a stage 4 testicular tumor, we need to look at 3 important features. Presence of non-pulmonary visceral mets in a seminoma qualifies the diagnosis of an intermediate prognosis stage 4 testicular tumor. If a non-seminomatous germ cell tumor has a mediastinal primary site, or has non-pulmonary visceral mets, or has very high alpha-fetoprotein beta HCG or LDH, the diagnosis of a poor prognosis testicular tumor is made. If the markers are neither low nor high, it becomes an intermediate prognosis tumor. And if the markers are low, it becomes a good prognosis tumor. So, a testicular stage 4 tumor is classified as a poor risk tumor according to the MAGIC criteria if it qualifies the diagnosis, if it has intermediate and poor prognosis. All the other IGCC good prognosis stage 4 testicular tumors are classified as standard risk 2. That is the need for knowing IGCC classification with relevance to MAGIC risk stratification. Now coming to the principles of treatment. Primary surgical resection for all stage 1 tumors following monitoring for disease recurrence is the standard of care. For all other stages, an initial surgical resection will be followed by platinum-based chemotherapy. If initial surgical resection is not possible upfront, either a diagnostic tumor biopsy or a radiology and tumor marker-based diagnosis should be made. This will be followed by platinum-based chemotherapy and then followed by definitive tumor resection. So coming to individual tumors, all mature and immature teratomas are treated with surgery alone followed by observation. The role of chemotherapy in stage 2 to 4 immature teratomas is controversial. Coming to malignant testicular GCT, all stage 1 tumors, whether prepubertal or postpubertal, are treated with surgery and observation. Stages 2 to 4 require surgery and chemotherapy. Coming to ovarian germ cell tumors, if the tumor is a dysgerminoma in stage 1, the direction for treatment is simple. It is surgery followed by observation.
Sorry for interrupting. How many slides are there?
I'm done, ma'am.
Yeah,
this is the last slide. Yeah. Surgery followed by chemotherapy. For non-germinamatous germ cell tumors, one should remember that surgery and observation for stage 1 tumors will lead to an event-free survival of only 52%, but can be 96% salvaged after offering adjuvant chemotherapy. All non-germinamatous germ cell tumors in post-pubertal children require chemotherapy following surgery, and unresectable tumors should have chemotherapy followed by surgery. BEP, which is bleomycin etoposide and cisplatinum, are the treatment for pediatric tumors used in the European protocols, whereas carboplatin is used in protocols in the UK protocols. The North American uses PEB and UK protocols use JEB. And this is how we follow up monthly, both with tumor markers as well as imaging. Thank you. The person here on the left is the one who discovered cisplatinum, and the person here on the right is Dr. Einhorn, who first used cisplatin in germ cell tumors. Thank you very much.
Thank you, Jyoti. That was a very nice presentation and extensive presentation. And we'll take the questions in the end. May I know, Dr. Shweta, ma'am, are you there? Dr. Shweta?
Yes, I'm here.
Yeah. Ma'am, this next will be a talk by Dr. Shweta on surgical guidelines, gonadal germ cell tumors. Over to you, ma'am.
Right. I would like the screen sharing rights, please.
Ma'am, you can share.
Okay. Screen visible?
Yes,
Yes, ma'am. Yes, ma'am.
Okay. Am I audible clearly?
Yes, ma'am. Yes, ma'am. Go ahead.
Great. So very quickly, most of it has been already covered by Jyoti. What I would do is kind of, summarize the whole thing in the same manner as she has done it, emphasizing on some few surgical aspects. So the goals of surgical management in any gonadal germ cell tumors in pediatric patients, I'm sure you know, complete tumor resection. But is that it, or is there something more? So there is an and along with it, and that is preservation of reproductive function. Obviously, it is not always possible, but whenever possible, we have to keep it in mind that we need to preserve the reproductive function. In adults, that may or may not be true because depending on the age of the adult, the reproductive function may not be required to be preserved. But in children, all of them require preservation of reproductive function. So we saw that preoperative, there are some investigations which need to be done in both in boys and girls. And intraoperatively, there are certain factors which need to be taken care of. Obviously, we are not going to be dealing with the post-operative phase over here today. Now, the risk stratification or the risk grouping is dependent on staging, meaning they are all interdependent, risk grouping, staging, and surgical decisions. But is it always that we need to do a risk grouping and then it would be staging and then the surgical decisions, or can it work the other way around as well? So most of the times we do staging, but many times I'm not talking of personally one institute, but many a times the risk stratification is missed out. But what happens is when we do staging and take a surgical decision, the surgical decision also has an impact on the staging, which means that if we do a surgery in a particular way based on what stage the tumor was, it is possible that the stage is different post-operatively. So this factor has to be taken into account, and we need to plan the whole surgical excision of the tumors in a way that we are not causing upstaging of the tumor. So let's look at the guidelines for stage 1. Now stage 1 is also risk group low. In this radical orchidectomy, which is high inguinal orchidectomy, delivery of the testicle via the inguinal incision and no scrotal incision, control of the cord structures immediately after the resection is extremely important. Lymph nodes generally in stage 1 in a low risk group need not be taken care of, but we do need to reassess if the lymph nodes are 1 to 2 centimeters, we need to reassess at 4 to 6 weeks. If they are still positive or if they are still enlarged, then treatment is to be given in terms of chemotherapy. And if it is more than 2 centimeters, again chemotherapy needs to be given. Usually there is no chemotherapy required, as Dr. Joshi also mentioned. Anyway, we are on the surgical part, so we would be focusing more on the surgical part. In stage 2 to 4, which is standard risk, radical orchidectomy, as mentioned earlier, and residual retroperitoneal nodes. Now, if the children are less than 11 years, prepubertal, then biopsy of these retroperitoneal lymph nodes is advisable, and chemotherapy as and when required. So this is high inguinal orchidectomy. The entire cord at the internal ring is dissected, ligated, and then the entire testicular tissue is dissected from the scrotum, pulled out into the inguinal region, and then excised. Now, transscrotal biopsy is what we have seen in patients who come in. Sometimes they come in, sometimes Now, transscrotal biopsy could be operative or it could be through guided biopsy, ultrasound guided biopsy, needle biopsy, FNAC. FNAC does not really alter any course of the disease, but open transscrotal biopsy is an absolute no. What are the major problems with the transscrotal biopsy? It does not even just upstage the tumor only because of the involvement of the tissues, the skin, the subcutaneous tissue, the dartos fascia, and all those tissues over there, but it also causes breach of the capsule. So breach of the capsule per se is itself a tumor upstaging feature. So both the conditions, either through a transscrotal biopsy or breach of the capsule or tumor rupture while you are delivering, even like in Wim's tumor, if there is tumor rupture on table, then the stage is 3. In the same way, here also, if there is a breach of capsule during dissection or during removal of the testes, or there is tumor rupture, then there is upstaging. So these two factors have to be taken care of at any cost. Now, high risk group is all those children, the post-pubertal children. They could be anything from 2 to 4 stage. They need radical orchidectomy and the residual retroperitoneal nodes. Now, if the retroperitoneal nodes are more than 1 centimeter, then RPLND is definitely advisable for these children. Let's see what are the surgical guidelines for the ovarian tumors. So here, most of the tumors are either taken into consideration as a unilateral tumor or bilateral. There are not major differences in unilateral or bilateral tumors, but the entire surgical guidelines are given differently for both the conditions. So a low risk group is stage 1, where only surgery is enough. Most of the times it needs to be laparotomy. But if the tumors are small, now it has been mentioned that the laparoscopy can be considered for tumors which are less than 10 centimeters. But there are specific further guidelines as to how the tumor should be retrieved and how the tumor, it cannot be morcellated. It has to be put in a bag immediately. If there is any aspiration of any cystic structure within that tumor is to be done, it has to be brought out and then the aspiration is to be done. So if we take care of all these guidelines, a laparoscopic ovarian tumor resection can be done. So along with the just removal of the tumor, there are many other things that needs to be done during surgery of any ovarian tumor, whether it is stage 1 or it is stage 4. So there is inspection of peritoneal surfaces, omentum, the retroperitoneal nodes. Any suspicious lesions have to be biopsied or excised depending on the size. Peritoneal fluids have to be collected. If there is no peritoneal fluid, then washings are to be taken from the peritoneum and sent for cytology. Contralateral ovary is always to be inspected in spite of the preoperative CT scan. And it's generally not very difficult to inspect the contralateral ovary. And any lesions, suspicious lesions are to be biopsied. The ovarian tubes, the fallopian tubes are to be preserved. Uterus is to be preserved if it is uninvolved. If it is involved, then we need to excise or biopsy that area. And capsule disruption again is to be avoided because if capsule breach occurs, then the tumor is upstaged. And ovarian sparing approach has been talked about, has been done, has been taken into account, depends on what is the size of the lesion and how much of ovarian tissue is visible on table. Now this is a small tumor, so it can be excised, only the tumor can be excised. And we need not remove the ovary completely. When it is bilateral, where if even in low risk group, there is normal ovarian parenchyma preservation becomes more important. So your excision becomes much more critical, meaning the way the dissection is done and preservation of the ovary becomes much more critical. If it is demarcated lesion, then it becomes easy to completely excise. If it is infiltrating, then and no ovarian tissue is seen, then it is preferable to do a bilateral biopsy and then give chemotherapy and then reoperate as required. In stage 2 and 3 unilateral tumors, with which is as per risk grouping standard group, the surgery remains similar as in stage 3. But yes, we need to take into consideration the size of the tumor. So here, NACT to be given or surgery to be done first, depending on how much is the what is the size of the tumor and how easy or difficult it is to handle the large masses. Now, in bilateral tumor, again, it is the same concept. Stage 2 and 3 with the standard risk group, preserve the normal ovarian parenchyma. And if it is demarcated lesion, discrete lesion, excise it. If not, then biopsy followed by chemotherapy and further surgery. When it is stage 4 with a standard risk is in pre-pubertal girls. Radical excision post chemotherapy is definitely advisable. Post chemotherapy excision will depend again on the response to therapy. And here, why we are talking of radical excision is because there are high chances of cure in these girls. When there is a post-pubertal girl in the high-risk group, we can't really pre-plan the extent of the surgery. It depends on a case-to-case basis. Obviously, chemotherapy would be the most important treatment modality for these patients. So to summarize, in testicular germ cell tumors, complete excision of the tumor is to be done through high ligation and division of the cord, and excision and removal of the entire lesion through the inguinal incision. In pre-pubertal boys, no lymph node excision, even if it is enlarged. But in pure post-pubertal boys, more than 11 years, RPLND, that is retroperitoneal lymph node dissection, is to be done if the nodes are persistent post-chemotherapy. The lung metastasis also, whatever the residual metastases are there, those need to be resected post-chemotherapy. To summarize the ovarian germ cell tumors, a complete resection of ovarian tumor with the preservation of ovarian tissue as and when feasible needs to be taken into account. Salpingectomy is to be done only when there is direct tumor involvement. Cytology is an absolute must, whether there is ascitic fluid or not. If there is no ascitic fluid, a peritoneal washing is to be done and the sample has to be sent fresh. A complete intraperitoneal staging needs to be done. Uterus and the contralateral, ovary. I don't know how this got, testes is not, uterus and contralateral ovary is to be examined and biopsy is to be done if there is any lesion suspicious. Omental biopsy or omentectomy is to be done if there is suspicious of gross disease. And abnormal lymph nodes more than 2 centimeters are to be excised. Though if the lymph nodes are normal, there is no sampling which is required for these lymph nodes. Thank you so much.
Thank you, ma'am. That was an excellent presentation and to the point as usual. We'll take the question in the end. Thank you. Now I may request Dr. Pablo. Pablo, sir.
Yes.
Can you start the presentation, sir? Can you share?
Yes. Just give me a minute.
Sir, kindly.
Okay. Are you seeing my screen?
Yes, sir.
Okay. Well, Thank you for the invitation. It's been a wonderful webinar so far. So I will just briefly talk about different locations of the extragonadal GCTs. It's interesting that it has been described, the distribution and the age peaks, and when you look at the neonatal cancer, you know, the young children, young babies, newborn babies with a tumor, what you will see is that the germ cell tumors are the for by far the most frequent tumors, malignant tumors you will find. And on the other hand, when you see the risk of cancer throughout life for preterm babies, the GCTs have an odds ratio of more than 5 for babies who were born prematurely. And so this is another thing we have to consider with the background of the patient if it was a premature baby. So about the locations, the sacrococcygeal teratoma is the most frequent GCT presenting extragonadal site at all ages, and mainly because of the involvement of the newborn patients. Usually the sacrococcygeal teratomas are usually prenatally diagnosed, and when you have a very large vascularized tumor, this may be a high-risk pregnancy with up to 25% mortality before birth. And the main surgical topic or guideline for the treatment is that the tumor must be completely excised, including the coccyx. And this is very important, as you will see. So when we look at prenatally diagnosed sacrococcygeal teratoma, there are some the people have been looking for predictors of poor prognosis, looking for what to identify which patients would need prenatal treatment. So if you see that this is one of the ratios that have been describes relating tumor volume with fetal weight, and when this is over 0.12 under 24 weeks of gestation, the patient is predicted to have a poor fetal outcome. As it has been shown, this is the Altman classification for the sacrococcygeal teratomas, and yeah, this is important for diagnostic workout and also for the treatment strategies that are being selected for each individual patient. And mainly you will have that Altman stage 1 is mainly extra-abdominal tumor or external tumor, and you will go through the Altman stage or type 4, which is a completely intrapelvic tumor, mainly, and most of them can even reach the upper abdomen. This is a case of a prenatally diagnosed case when which had an external tumor, and you can see here the prenatal ultrasound seeing a mostly cystic lesion, and on the other hand, here on the right you can see a fetal MRI showing an MRI showing that the tumor is it's getting in contact with the coccyx and also the inferior part of the sacrum. The tumor is mostly cystic. We could say it is an Altman 1 or 2 type. We decided for this patient a posterior approach. We thought it was a good case for going for a midline incision. And most of the patients with bigger tumors will be warranted a chevron incision, but for this kind of patients, we prefer to use a midline incision. And see that we use intraoperative neural monitoring of the pelvic nerves, which is very useful when, especially for big tumors. And dissection must be very careful, trying to avoid damage to the surrounding structures, especially the pelvic muscles and the sphincter. And here you can see that the coccyx was included in the resection, and this is very important to avoid recurrence. This is another case, or another patient that was diagnosed prenatally, and you can see here fetal ultrasound showing an intrapelvic mass that was confirmed by a fetal MRI that showed a pelvic mass which is rising up to the abdomen and displacing the bladder to one side. And so this is when the baby was born, it was considered as an Altman 3 or 4 type, because somewhat it had also an external component. So we decided a combined approach by a laparoscopic approach to do the dissection of the abdominal component of the tumor, and then we went for the through a posterior approach to do to complete the resection of the tumor and to perform the cosegectomy. So the surgical recommendations for sacrococcygeal germ cell tumors is to perform a surgery with an adequate wide enough access in order to be sure that you are resecting completely the tumor, with trying to avoid tumor rupture and leakage in the tumor field, and preserving normal structures. Intraoperative monitoring of pelvic nerves is an important issue to help avoid resecting or cutting the nerves. For tumors, for big tumors, it may be useful to perform an early ligation of the medial sacral artery. It is also important for big tumors to have an adequate control of distal aorta in case you have any lesions or bleeding. Always look for rectal wall lesions after finishing tumor resection, as some of these tumors may have adherence, may be adhered to the anterior rectal wall. Reconstruction of gluteal muscles is important to try to avoid late sequelae on continence and also a good cosmetic result. And again, don't forget to do a complete coccytectomy. Sometimes, especially for big tumors and when you have some fibrosis, and especially for those rare patients that have been submitted for chemotherapy, for upfront chemotherapy, it's not always so easy to identify if the coccyx has been resected completely. For these cases, rare cases, sometimes may be useful to do a radioscopic control just to check if the coccyx has been completely removed. So what about malignant sacrococcygeal teratomas? Even when you consider all the sacrococcygeal teratomas, it has been reported somewhat high incidence of recurrence, which can be even beyond 5 years postoperative. Chemotherapy is only indicated for malignant tumors that have not been completely resected. I am talking about neonatal sacrococcygeal teratomas. When you have, it may be acceptable to leave microscopic residual if you have no evidence of elevated tumor markers, and finally the histology shows that it's non-malignant teratoma. And survival is conditioned mainly by histology and by recurrence. When you see, when you compare the survival curve between the mature teratoma patients and the malignant teratomas, the histology, of course, is a significant predictor of survival. And also for survival, if the tumor relapses, those tumors that have no relapse have a much better survival than those who have a recurrence. And that's why it is so important to assure that the coccyx has been completely removed, as it is one of the the main significant factors of recurrence. So moving on to other locations, the mediastinal GCTs are the thorax are probably the second most frequent location. They are mainly located at the anterior mediastinum. It has been said that association between mediastinal GCTs and Klinefelter syndrome is very important to know. So any patient with previously diagnosed Klinefelter syndrome presenting with respiratory symptoms should be investigated for a mediastinal tumor. And on the other hand, when you have a male patient with a mediastinal GCT, a Klinefelter syndrome should be ruled out. Usually when presenting in newborn babies and young babies, the most frequent finding is mature teratoma, but when they happen in older children, the rule is that most of them may have a yolk cell tumor. And also there are some other clinical associations that should be taken into account. What about the strategy for those patients? As it had been said, if tumor markers are positive and you have this kind of mass, a solid cystic mass, usually the treatment, chemotherapy, can be initiated before surgery. If tumors are negative, sometimes percutaneous biopsy is our first option. And when it is not available or material obtained is not sufficient, you can go through a thoracoscopic biopsy or even an anterior thoracotomy when you have to do in an awake patient. The surgery will aim to complete macroscopic resection, and it is indicated in well-defined lesions, usually after chemotherapy. And so, but this is very important. This is for all mediastinal tumors, but being mediastinal GCTs can be really big masses at the anterior mediastinum. And so it is very important before performing a surgery or a biopsy under general anesthesia to rule out airway compression by the tumor. You can suspect this by the patient looking for the patient is asking if he has or she has orthopnea. Look for airway compression when it is over 1/3 of compression at the CT scan, or if you have a reduction on the expiration peak under 40-50% in functional studies. So this is very important to be considered before any surgical action is taken. What about the approach? It will depend on the side of the max and also the previous imaging. You can choose for an anterior approach like median sternotomy, a clamshell bilateral thoracotomy or a lateral thoracotomy or thoracoscopy if the lesion is well defined and small. This is an example of a patient who was operated through a midline approach with a sternotomy. This was a really big mass that could be dissected um, from the surrounding structures. Sometimes, especially in patients who have been submitting to preoperative chemotherapy, you have to have the aid of a cardiac surgeon, and eventually the adherence to the main vessels may be significant. So these are not easy surgeries, as tumor may be very adherent to the big vessels. This case, the complete resection was achieved, and the patient did very well. So you have also head and neck and thoracic location, especially head and neck. For this kind of patients, when presented prenatally or in the newborn patient, there is a high risk of airway compression, and the patient may have a neonatal asphyxia. So prenatal diagnosis in some of these cases may be life-saving. If you are able to make a diagnosis at before week the 28th week or between 28th and 36 weeks gestation, an exit procedure may be needed to make sure that you have a patent airway and the patient is protected from to be asphyxiated. Um, Early surgical resection may be indicated, and it may be delayed if the tumor is not easily resected when you have positive tumor markers. This is what we do when we have prenatally diagnosed patients. The team operating room is usually very busy, and here you can see the patient who is part of the newborn babies outside the mother's abdomen, and the placental circulation is preserved, and the pediatric surgeon here is doing a bronchoscopy and assuring intubation of the patient. And you can see the newborn baby here with a big solid cystic mass which was compressing the airway. This is another case showing the fetal MRI with a big tumor, also completely compressing the airway. And in this case, intubation and regular intubation was not possible, so a surgical way to the trachea was needed, and a retrograde intubation was performed. Just I think this is my final slide. For patients presenting in the newborn period, I think it's very important that LMICs should focus on improving prenatal diagnosis, because we having a better pre-treatment assessment, it's very important for high risk cases. In most cases, adequate or complete surgical excision is enough. 10% of neonatal tumors may contain foci of yolk cell tumor, so always look for tumor markers and consider that the tumor may be malignant. And of course, this will be very important for older patients. And of course, usually, perhaps as besides that you have a small tumor that may be easily resected, most of the patients, in most of the cases, surgery should be delayed in presence of positive tumor markers, and chemotherapy would be performed first. And it is very important to follow up the patient with imaging and tumor markers in the long term, because if they have, there is some evidence of late recurrences even after puberty. So this is really very important. I would like to introduce to you all this surgical practice guidelines were published by a significant number of authors from high-income countries and also low and middle-income countries, from our society, from IPSO. It is available online. It is free access. So here you can find the guidelines, surgical guidelines for all of the tumors that you can find, and of course, including GCTs. Thank you very much.
Thank you very much, sir. That was a very nice presentation, crisp presentation. Quickly, we will move to the few case discussion, and simultaneously all the queries will be tackled. The rest will be asked in the end.
I will stop. Yeah.
Coming to the first case, a 2-year-old female with fever of 15 days and abdominal distension for 2 days.
Dr. Prasanna, your screen is not, I mean, slides are not shared.
Can we now?
Yes, I can see. Make
Yeah,
it.
Okay, 2-year-old kid came with a history of fever for 15 days, distension, abdominal distension for 2 days. It's a huge distension.
Full screen, Dr. Prasanna, full screen.
That's full screen. This looks full screen. My computer is showing full screen.
I think you can go forward. It is not.
Yeah. Okay, diagnosed and initially diagnosed as dengue fever in view of low platelets and severe distension. Child was irritable, tachypneic. Per abdomen, there was a gross distension, tense ascites, and fluid thrill were also noted. On further examination, a firm was felt in the deep palpation. She has a decreased breath sounds on right membrane infra-axillary area. On ultrasound, the 2 solid cystic lesions, there was a right lumbar mass around 10 into 8 into 5 centimeter, and in the midline to hypochondrium, there was one more lesion, 8.7 into around 7 into 5 centimeter, with gross ascites and right-sided moderate effusion. So, just a question, Dr. Jyoti, what would be your next action of plan in this condition? Hello?
So this is a child who has a 2-year-old with an intra-abdominal mass. So any mass, abdominal mass in an infant or a child has to be considered malignant unless proven otherwise. I would like to investigate this child. I would first look at the location and the characterization of the tumor of the mass using an ultrasound abdomen. And I would also order blood investigations inclusive of tumor markers, like I had mentioned previously, alpha-fetoprotein, beta-HCG, LDH, and urinary VMA, particularly considering that this mass is in the midline.
So what will be your differentials?
So if there is a huge abdominal mass occupying mostly the midline, I would, in a 2-year-old child, I would think of neuroblastoma. Germ cell tumor is the other possibility. Other abdominal masses like Ewing sarcoma or retroperitoneal RMS, all of these considered in the differential diagnosis.
Okay. As we did the workup, blood workup, LFT, RFT, and are normal. Even serology markers are normal. Coagulation profile are normal. Coming to tumor markers, I'm sorry. The AFP was 21,923. And beta HCG was.
So your slides aren't moving.
Slides are not moving. Should I share if it is?
Yeah.
Dr. Prasanna, are you allowing me to share?
Yeah, sure. Yeah.
You'll have to basically stop sharing the screen, then I can share. Yeah.
Okay.
visible now?
Yes, yes. Okay, click.
You want me here?
Ma'am, Monica ma'am, your slides are not open yet.
They're not open. I am actually sharing it.
Okay, okay, ma'am.
Can you see it now?
No, 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 no.
Now?
No, no.
Yes,
Yeah.
yes, now
Yeah,
we can.
yeah.
Yes, ma'am.
Okay. Where do you want me? Is
Next,
it
next, next, next.
next?
Yeah, yeah. Now, Dr. Hiren, are you there?
Yes, I'm here, very
Yeah,
much
yeah.
here.
Can you just read if you don't mind? This
Yeah,
is a CT of the same patient. Yeah.
so we can see here that the lower abdomen and pelvis sections are being seen here. And what we are seeing that lobulated solid cystic masses are seen in both sides of the abdomen. And you can see that in between in the last slide, uterus is seen in the midline. So when you see this kind of bilateral adnexal masses in the pelvis and which are going superiorly into the abdomen, which are solid cystic in nature, your first differential when you are not separately seeing the ovaries, then you should think of ovarian tumors. And in this age group, the germ cell tumor should be the first part. And so when we are looking at this thing, we should carefully evaluate the local as well as distant adenopathy. We can see here there is some sort of cross ascites also in the abdomen. I assume that there are no liver or splenic lesions. Now, in germ cell tumor also, like if you see visible fat or calcification, then you can say that it could be some sort of teratoma. But here I am not seeing obvious any areas of fat or calcification. So it could be some sort of non-teratoma variety of germ cell tumor. That is one of the possibility. And depending on the age and the presentation, you can add differentials of non-germinomatous tumor also. But here, looking at the history, it may be one of the germ cell tumor, which is not teratoma, which can be something else, like a York-Sick tumor or some other variety, mixed variety. So that should be our approach. Yeah.
Yes. Given by the tumor markers and the radiology, it looks like more of a mixed germ cell tumor.
Okay.
Yeah, next slide. Okay. Now, Dr. Jyoti, how can we proceed from here? What would be the plan of action?
So we have, we clearly now know that there is a tumor mass and this child has positive tumor markers in the presence of elevated alpha fetoprotein and beta HCG. So this is probably a mixed malignant germ cell tumor with both yolk sac and choriocarcinoma elements. So from here, I would, it looks like an unresectable tumor. So I would probably proceed, risk stratify this child. This is an under 11-year-old non-germinomatous germ cell tumor with metastasis to the liver. So I would risk stratify it as a poor risk germ cell tumor and proceed with neoadjuvant chemotherapy.
Sushmita ma'am?
Yes.
Yeah, I just wanted whether it is preferable to do CT or MRI given the condition because there was a gross ascites in this patient and sorry, yeah, continue.
Yes, so generally the preference of the choice of investigation is based on what the surgeon is comfortable with and what is easily available within the institute. So MRI is always superior whenever we want to study soft tissue and the details of such type of lesions. MRI is always better. But if we are talking of individual preference, it depends on so many other factors as well.
Okay, yeah, got it. Dr. Jyoti, just wondered, is there any scope for biopsy in this patient?
So, if we go by first principles, radiologically confirmed abdominal mass with elevated tumor markers, it obviates the need for a biopsy. It is definitely a germ cell tumor. There is no doubt about the diagnosis.
Can I just add, why don't
Yes.
we do a peritoneal, meaning ascitic tap and send that fluid for cytology? Isn't it much simpler? And in fact, it will also give us an information of whether there are peritoneal seedlings as well, which is obvious, which is kind of obvious, but then we will have some, we will have an advantage of doing an ascitic tab.
So with or without ascitic tab, this is clearly a stage 3 tumor because germ cell tumors are known to have peritoneal seedings causing malignant ascites. So in the presence of an imaging and tumor marker elevation, neither biopsy nor cytology may be required here, ma'am, because it would only add to our staging information, presence of malignant cells on the peritoneal fluid. Since we already know that it is stage 4 and there is ascitic fluid for a local stage 3, it is not going to add any extra information from what we already know, is what I feel.
Right. So another point is, would ascitic tab, I was mentioning about ascitic tab and cytology, would it not help the patient to tolerate the chemotherapy better? Because it's like massively distended abdomen and gross ascites.
So here the ascites is going to reaccumulate because it is malignant ascites, just like any malignant collection of fluid. The moment we tap, it is going to reaccumulate. So the best way to bring down the ascites in this child is to start chemotherapy as soon as possible.
Just this thing, if the child is having severe respiratory distress, maybe simultaneously tapping to reduce the distress and chemotherapy is to be started simultaneously.
Yes. So, but this particular child did have pleural effusion ascites, but was not in respiratory failure. And the child had reasonably stable vitals. So that is the reason we proceeded with NACT without going ahead with therapeutic tapping.
Okay. Just a quick, is there a chance of missing a metastatic, especially considering the small child with so much of fluid? Dr. Hiren?
Pardon me, what you are saying? What's the question?
Is there a chance of missing a metastatic if there is a severe amount of fluid in the pleura as well and the pleural effusion and ascites?
No, if you have done adequately protocoled contrast images, you generally the nodules or whichever deposit which are more than 3 millimeter, it should be picked up on the CT if you see carefully thin sections. In fact, if it is large ascites along the lining of the peritoneum, the nodules will be seen much more clearly. So I don't think that that can be missed. But if you are not included the thorax in your CT abdomen part, or you miss the CT thorax, then for the entire staging workup, you should do that thing.
Yeah, got it.
Yeah.
Thank you. Next slide, please. Okay, metastatic imaging, NCCD test, there was no lung involvement. CT abdomen, there was a query suspicious liver lesion was seen in this patient. Next. So, okay, what will be the stage and risk stratification? This was already covered, need for biopsy. Was there any feasibility of upfront surgery in this patient? Dr. Pablo? Sir?
Yes, thank you. I think about stage and risk and the need of biopsy has been already addressed. I would certainly not go for an upfront surgery for this patient because of the extensive abdominal disease.
Okay.
You will not be able to do a complete resection. Sorry?
Yes. Okay, got it. Yeah. Next, ma'am. Okay, this is the staging and stage 4, this one. Okay, now Dr. Jyoti, what was the chemotherapy you chose for this patient?
So the chemotherapy we chose was the European protocol, which is a carboplatin based protocol. There is always this controversy whether cisplatin is superior to carboplatin based on adult data. But the recent MAGIC consortium report based on the retrospective data of the COG and CCLG studies has clearly stated that carboplatin is as good as cisplatin. However, this is pending the results of the ongoing trial, which is trying to compare cisplatin and carboplatin, which is a COG trial. Now, why did we use carboplatin in this particular child and not cisplatin, which is our department practice? That is because this is a child who has ascites, who has pleural effusion. We are worried about respiratory failure. Fluid balance is going to be a real challenge in this child. Compared to cisplatin, carboplatin is technically very easy to deliver as it does not require any pre-hydration, diuresis, or post-hydration. So based on the clinical condition of the child and need for an easily administrable drug, we chose carboplatin over cisplatin.
Thank you. Just a quick thing. Is a carboplatin better tolerated than cisplatin in children?
Yes, sir.
Or-
Carboplatin, the most important complication is cytotoxicity, myelosuppression. Whereas cisplatin has nephrotoxicity, neurotoxicity, it is highly emetogenic, ototoxicity. This is the toxicity profile. Definitely carboplatin has a better toxicity profile compared to cisplatin.
And this child had some mild renal derangement, so all the more reason we use the carboplatin. Okay, just this thing, is cisplatin more effective than carboplatin in GCT?
So like I said, in adults, it has been clearly proven through randomized control trials that cisplatin is superior to carboplatin. However, in children, the only data we can rely on to prove the non-inferiority of carboplatin is the MAGIC consortium data, which is based on retrospective studies. There is no RCT so far with results which has compared cisplatin and carboplatin in children. But our MAGIC data has shown that carboplatin is non-inferior and equivalent to cisplatin. And to explain why the adults had better outcomes with cisplatin compared to carboplatin, two reasons were proposed. Number one, the AUC which we use for administering carboplatin in children is 7.9, whereas it is less than 5 in adults. The second reason is our dose intensity. The dose intensity that we deliver for children with germ cell tumor is every 3 weekly, compared to every 4 weekly delivery in adults. These are the two possible reasons for the poor outcome seen with carboplatin in adults as compared to cisplatin.
Thank you. Dr. Shweta ma'am, just this thing. How many surgery will be considered at the end of the chemotherapy, or if in the interim only if there is a regression is seen? So when the surgery should be considered? Ma'am?
For these germ cell tumors, chemotherapy, post-chemotherapy response, generally after 2 cycles is assessed. If after 2 cycles the alpha-fetoprotein has dropped, the tumor would not obviously regress completely in 2 cycles, then I would take up the patient for surgery. And if we don't see much of response with the chemotherapy, with the drop in alpha-fetoprotein, then another 2 cycles can be given, and after 4 cycles the patient can be taken up for surgery. And 4 generally, as per my practice, is the maximum basically. And now after that we excise whatever tumor it can be excised, and then further chemotherapy is to be planned after proper histopathology of the specimen.
Okay, thank you, ma'am. Just this thing, if there is a tumor fall in the tumor marker, but the tumor size is same, or maybe not so much, is a partially respond, still we go ahead and for the surgery, or give another 2 cycles? What's your plan?
Yes, if the tumor size is not regressed, but the tumor markers have regressed, usually it doesn't happen that way in GCT especially. In liver tumors, this happens, that the tumor markers reduce, but the size of the liver tumor is the same. In GCTs, usually we can corroborate the response with the alpha-fetoprotein levels dropping and the size of the tumor. But supposing, if you're saying hypothetical situation, that it does not reduce in size, then yes, I would want to give another 2 cycles of chemotherapy and then review the patient for surgery.
Thank you. So, Pablo sir, what is your opinion on the same thing? Whether you give 2 cycles and
I agree with that. I think it's very important to have a good communication between the oncologist and the surgeon, and it's closely looking for the patients as a response to chemotherapy. I think to think about going for surgery every 2 cycles, it's a good approach. And of course, the tumor markers decline is very important to be taken into account to make decisions.
next slide, please.
I may just add another point. There has been comparison of delayed surgery with second look surgery from Tata Memorial Hospital, Mumbai. And they found that in selected patients who have normalization of tumor markers and significant regression of tumor, a second look surgery yields the same results as a delayed surgery.
Thank you. In this patient, you can see the progressive decrease in the AFP levels and beta HCG, and it is almost normalized at the completion of chemotherapy. So next slide. Yeah, this is the one. So post chemotherapy. Next, sorry, the previous slide, please. Yeah, Dr. Hiren, can you just explain the current CT post chemotherapy?
Yeah, so post chemotherapy, what we are seeing that now the mass has shrink in size. What we are seeing that is it the same patient or a different patient?
Same, sir, same.
Same patient. So now what we are seeing that the mass is like encasing the IVC, and it's also expanding into paracaval, aortocaval region. And what you are seeing that on the coronal images on the left side bottom, you can see that hypo-enhancing area or filling defect in the IVC, which might indicate that there is evidence of some sort of is there a like a suspicious infiltration into the IVC that on coronal looks like that, and there are like the lobulated mass is seen in the retroperitoneum that we can see, which is encasing the IVC and partly to the aorta also, and it is uplifting the IVC anteriorly.
Next slide. Thank you.
Yep.
Sir, what will be the next plan? We have completed the chemotherapy and the tumor markers are normal and we have a residual tumor.
Yes, it's a pretty challenging patients to go there. Of course, you have to resect, as Dr. Susmita is saying, the completely resect the lesion. I was asking at the chat, what is the role? Of course, if you have it available to do a PET scan before surgery to know if this residual mass is probably a viable tumor or not, but you have to go for resecting the whole mass. It's a challenge because after chemotherapy, GCTs usually are very adhered to the vascular structure, so you have to do a very careful vascular dissection and resect the whole tumor, which will be a difficult surgery, of course.
So you can see that in the CT it was very close to the right renal vessels, IVC, and even to the aorta. So how far you go, sir? How much or to what an extent you can do a surgery in this? So resect IVC or compromise on the renal vessels?
I think that the renal vessels were not encased by the tumor or were them, but you have to completely dissect the whole IVC and the aorta, especially you have tumor there between the aorta and the IVC, so you have to do a complete dissection and resect everything you have there. And about the question of lymph nodes, usually in this kind of patients, there's only a mass, which is you cannot differentiate which is lymph nodes or mass. So I would try to take everything out if I could.
Thank you, sir. Dr. Jyoti, as we discussed, can you just elaborate on that PET CT, what sir was asking?
So what is the role of PET CT in germ cell tumor? So let's come to three important aspects: diagnosis, follow-up, and relapse. At diagnosis, PET CT offers no advantage over CT scan because the sensitivity and specificity of both the modalities is the same. That is 80% sensitivity, 95% specificity. What about follow-up? During follow-up, CT again PET-CT does not offer any other advantage over CT scan. But the only advantage of PET-CT scan in germ cell tumor is in the presence of a biochemical relapse, where we are not able to pick up the primary lesion. So in such a scenario, to evaluate the cause of the biochemical relapse and to localize the site of relapse, a PET-CT may be indicated. But despite this, we may fail to localize the lesion in the presence of an early biochemical relapse.
Yes, we have seen that case where there is a biochemical relapse and for primary tumor we are not able to.
Yes, that is the only indication for PET-CT.
Okay, can I give the next slide? Thank you. Yeah, we went ahead and did the surgery. The tumor was very much encasing and to the right renal vessels and the part of the aorta. The capsule was densely added to the aorta and IVC. So we have to take out only the tumor leaving behind the capsule. We didn't dissect so much. And there was one big node, iliac nodes was resected, and there was no other lymph nodes there. And luckily, the whole of the lymph node and this mass squamous, there was no active tumor cells, and only post-chemo changes were noted. And on follow-up, the child is doing well. Next slide, please. So, Dr. Anpurva, ma'am. Dr. Anpurva Datta, ma'am.
Yeah, please tell me.
Can you just elaborate on the cytology and the post-chemo, ma'am? What will be this thing where you can't see any active tumor cells?
See, post-chemo specimen, if there is response, then I will not be seeing tumor. I'll just be seeing the tumor bed. So tumor bed will show me inflammatory cells, macrophages, and hyalinization and necrosis. So I cannot say which tumor was it. So if there is no residual viable tumor, if there is residual viable, then maybe I'll see the morphology, and depending on that, I can tell you which tumor was it.
Okay. Thank you, ma'am. I just wanted to ask. What will be the role of IHC in GCT, malignant GCT?
Role of IHC will only help if I see any viable tumor.
No, not in case of this one, ma'am. In general, it is a biopsy.
Yeah,
Okay.
yeah. See, IHC is helpful when if I'm dealing with a metastatic site, you have given me a biopsy, and if I'm suspecting a germ cell tumor, then I might put few of my markers like SAL4, which is a pan germ cell marker, which will help me pick a germ cell tumor. And if depending on the morphology, I'll decide if it is suggestive of a seminoma or a yolk sac tumor, I'll put specific markers. So like for seminoma, OCT34 and CD117 are very helpful. For yolk sac tumor, Glypican-3 is very helpful. But that is all in the context of morphology. First, I will decipher the morphology, and then accordingly, I'll put the panel. Yeah.
Okay. Definitely, there is a role of IHC, and it may help in the differential of the.
Yes.
Yep. Thank you. Next slide, please. Okay. Now, Shushmita, ma'am.
Yes.
This you already mentioned in your presentation, role of preserving the tube. So there is a query: is there a chance of more ectopic pregnancy in this, or is the prevalence is same as any other thing? And the other thing is the role of frozen when we are doing preserving ovarian preserving the dissection. Two things.
Let me answer the second question first. There have been studies about frozen section on table to decide the extent of the tumor and for preservation of the normal ovary. But it has been noted that these frozen section studies are not really that accurate, and there still could be incomplete dissection, or it could be removal of the normal ovary. So frozen section is not the best thing to be done on table. Pre-operative investigations, including detailed CT and MR. I prefer MR over CT to differentiate the tissues, the cancerous tissue, the malignant tissue versus the normal ovarian tissue, and then plan the dissection accordingly, a meticulous dissection on table rather than relying on frozen section. So that is my take on that. About the first thing about ectopic pregnancy, actually I am not aware of what is the incidence. If Dr. Pablo can highlight on that, it will be great.
Sir, can you take that question?
Sorry, can you
Pablo?
repeat the question?
Yeah, is
Sorry,
there an increased chance of ectopic pregnancy if you leave the fallopian tube, or you need to resect the fallopian tube when you do operectomy? And number two, will you do a frozen when you're doing a ovarian preserving surgery or whatever gonadal preserving surgery?
We don't do frozen section when preserving the ovary. It's as we don't do that for testis sparing surgery for testicular tumors, and we also don't give support to changing our strategy at the operative room based on frozen section in that case. And about preserving the tube, it's not always easy to preserve when you have a huge or malignant tumor, but I agree with Dr. Sumita that the tube should be preserved. We have the evidence that we have on statistics on ectopic pregnancy and whatever. They are based on treatments on series that are 20 or 30 years old. So I think that nowadays, at the same time that it should be, especially for bilateral cases, the ovaries should be tried to be preserved. I think the tube should always be tried to be preserved unless it is macroscopically involved in the tumor.
Just ma'am, when we are doing that ovarian preserving surgery, is there a risk of breaching the capsule, or we need to open the capsule? Is there a high risk involved?
Yes, risk is there. Yes, definitely there is a risk, and that is why I mentioned a very meticulous dissection is required when we are talking of preserving the tube, preserving the ovary. Even the blood supply to the ovary need not be hampered, because if it is a tumor over there, you may not be able to differentiate the blood supply to the ovary versus the blood supply of the tumor. So all these things are not very simple. But in smaller tumors, it is feasible. In smaller tumors and also in more organized tumors, it is easy to see the difference between, even with the naked eye, we can see the difference between the tumor and the normal ovarian tissue.
It will be decided pre-op. I mean, based on imaging, you take a call, or you have to go intra-op and assess again.
So
what
imaging
will be the criteria
is,
when
yes,
you say
the plan is made on imaging, but the final excision plan is done on table. Always.
Yeah, thanks. Is there any criteria, ma'am, 2-3 criteria if you can remember, or any of your own thing where you can say, yes, this could be the one which we can go and try, other than the when it's bilaterally involved, in unilateral where we can try to preserve? Hello.
It usually, see, there are 2-3 factors. One is if there are any adhesions to surrounding structures. Second is there is a preoperative breach of capsule. How? By infiltration of the tumor. If there is already a breach of capsule by the tumor infiltrating, and the tumor infiltrating into the surrounding structures, it will be very difficult to preserve and even to identify the normal ovarian structure. Even if we identify, there could be microscopic tumor infiltration into the ovary. In that case, preserving will not really be of any use. Now, adhesions and the surrounding structures, how much are they infiltrating into through the capsule? It's not always evident on imaging. So all these things on table decide, and size of course matters a lot, because if it is a smaller tumor, then all of these dissections become so much easier. In larger tumors, this is not possible. Also, there is one more thing. If the lymph nodes are involved, if the lymph nodes are more than 2 centimeters to begin with, then the chances of preserving the ovary are a little less, because the tumor has already extended beyond the local area, and it has and the lymph nodes are involved. So the chances of ovary being involved are much more higher.
Thank you, ma'am. Very nice. Can you move on? Next slide, please. Yeah, Kiran, what will be the radiological signs that tell us about the benign nature of the germ cell tumor?
Well, if the tumor is less than 5 centimeter in size, if the tumor is more of a unilocular and predominantly cystic, then if you assess the content of the tumor, there are less of a solid contents and less of a enhancing portion of the tumor, and there is no adjacent surrounding fat stranding or any capsular signs that can suggest rupture of the lesion, or there is absence of local or distant adenopathy or ascites. These are the features that will favor that it is likely to be more benign. Now, if you consider that teratoma will have calcification, so teratoma also can have mature and immature variety, in which if you see that the calcification is more of a curvilinear and chunky, but it is more focal, with less of a solid enhancing component, then it is more favoring towards benign variety of mature teratoma. On the contrary, if you see that the calcifications are very irregular, dispersed throughout the parenchyma, not along the wall of the cyst or something, but they are throughout the parenchyma, and you are seeing much more heterogeneously enhancing solid areas, then probably you are dealing with the malignant or immature variety of teratoma. So to cut it short, unilateral lesions, small size, predominantly cystic, thin septa, less of a solid enhancing component, absence of ascites, absence of local adenopathy, this all will point towards that lesion might be a benign thing. You can, that these are the some usual features that you can assess. And other thing that recently that this dynamic post contrast perfusion curve also has been come up as a new modality in evolution of the ovarian tumors. So depending on the how rapidly the tumor shows washing of the contrast and how rapidly it shows washout as compared to the myometrium of the uterus. So you put your region of in enhancing portion of the ovarian tumor and other region of interest in the uterine myometrium, and you see the enhancement pattern. If the tumor is showing more increased enhancement and rapid washout, then it will favor more towards malignancy as compared to benign tumor, which will show lesser curve of the entire enhancement pattern, and it will be less enhancing as compared to the uterine myometrium. So these are some several features which has come up in the latest recent literature. Yeah, I hope this answers your question.
Yes, thanks.
Dr. Prasanna, I'll just like to make a small comment. So you were asking about ovarian preservation surgery. So probably the tumors which are like the Dr. Hiren just told us about the benign things, where we can try preserving the ovarian parenchyma. And the Sertoli or slow growing, basically stromal cell tumors, they also grow slow. So these are the places where we can go for ovarian preservation surgery. Most of the malignant germ cell tumors where the tumor markers are raised and they're large tumors, I think it is difficult to save the ovarian parenchyma. The only problem is when it is bilateral. So whenever there's a bilateral, you see one tumor is large and smaller, the other is small. So there are chances that we can save parenchyma for the second ovary, but that depends on how badly it is involved. So I just wanted to highlight this point.
Yes, yeah. Thank you. Next. Okay, next. Second case, the 2 years noted a lump in the abdomen 2 days, and it's a firm mass about 5 to 6 centimeters in the right lumbar region. It's a short history. Next. An ultrasound showed 6 into 8 into 5 centimeter in the right iliac fossa with mild internal vascularity. The lesion separate from the kidney and liver, adjacent to a small interstitial noted transient, and multiple nodes in the right iliac fossa. AFP was 15,403 nanograms per deciliter. Next. Okay, Dr. Naren, can you just brief with CT findings?
Well, we can see that here some sort of heterogeneously enhancing lobulated lesion, which is seen in the right lumbar region, which looks like to be peritoneal, and it is indenting on the right lobe of liver, especially the segment 6. I would say segment 6 and the 5 that we can see. Now, on this section, it is difficult to say whether it's arising from liver or it is just outside peritoneal mass. But most of the section, it looks like that it is outside the liver, it's just indenting on the liver capsule and causing scalloping of the underlying parenchyma. It looks like that.
Okay. How do you just differentiate whether it is scalloping or it is actually involving the liver? Can we differentiate? What will be the point?
Well, so if it is scalloping, then you will see that inner side concavity. If it is arising from the liver, it should show outside convexity, and you will be seeing some sort of internal architecture of the parenchyma also will be changed, and you will see that vessel will be differently oriented in if it is arising from the liver itself, and you will be seeing the mass will be supplied by the liver vessel itself when it's arising from the liver. But if it is outside mass, then you might not see the vascularity of the lesion from the liver vessels. It may be somewhere else from. So these are some salient point where you can make out that whether this mass is arising from the liver or it is from outside.
Yeah, that's this doubt arises because this lesion was in the right and close to the liver, and the AFP was elevated. Both can be seen in the liver tumor. That's why I asked. Considering the upfront resectable lymph mass from the liver was posted for surgery because initially it was query it was peritoneal or peritoneal liver mass. It was not from the liver, but it is from the peritoneal surface. So, what will be the plan, ma'am? Ma'am, if you can, what will be the surgical plan for in this patient?
So I actually have a question before I give you an answer to this your question. Why there was no biopsy done? We have discussed in the initial presentation only when there are masses from the liver, then biopsy is more of an indication rather than those in germ cell tumors. So if this was a mass suspected to be arising out of the liver, ideally we should have done a biopsy, right?
Ma'am, this patient was actually, basically lesion was looking small, upfront resectable. It was close to segment 6. So that is why that was the reason for taking the patient upfront. I mean, yeah.
Yeah, so that is the surgical plan. Resect the tumor. It is easily resectable on CT. So resect it.
Yeah.
Got it. Okay, next, please. The time running. Move next. Yeah. So margin and the staging done. It's intraoperative 5 to 7 centimeter arising from the peritoneal surface, and it was actually infiltrating the abdominal wall muscle. Few momental suspicious nodes were taken out, and minimal fluid in the peritoneal cavity. No other deposits in the liver or any peritoneal cavity, and no other lymph nodes were also noted. Next, please. So histology showed a yolk sac tumor infiltrating into the skeletal muscle, and tumor shows tubular microcystic area and area of necrosis. All cut margins were free of tumor, and momentum shows deposits of tumor. So IHC showed AE1 and AE3 and cyclin were negative, and CD30 and CT34 were negative. Sorry, positive for AE1 and AE3 and
What about the lymph nodes?
Lymph nodes were negative, ma'am. Only one momental deposits were positive.
So just to highlight, we were thinking of a liver tumor which came out as the yolk sac tumor from the peritoneal walls. And so we did all the staging workup which was required for that particular case. And because it was like a soft tissue tumor, we took out the margins also.
Dr. Anupurva, are you there, ma'am?
Yeah.
I just wanted that IHC. Can you just explain that
Yeah.
markers in the last?
Yeah.
I'm sorry, Dr.
yeah.
Anupurva, I have put your slide of the ISC.
No
in
issues,
the
no
end.
issues.
So we
No,
can
no
discuss in the
issues.
end also. Yeah.
No problem. Can you just show me the next slide?
Please. Next slide.
This is a case with elevated AFP, and in a child, I am expecting two tumors with elevated AFP. One is a germ cell tumor and another is a hepatoblastoma. And the thing is, this is not arising from the liver. It is peritoneal, and there are omental deposits as well. And what I see is this microcystic pattern, this honeycomb appearance, which you can see in histomorphology. So that is very characteristic of yolk sac tumor, and these eosinophilic deposits, red color globules. I don't know if you are able to appreciate or not. That is also very characteristic of yolk sac tumors, and it is the most common pattern of yolk sac tumor. But since it is a solid type of tumor, I would like to do few markers. And as mentioned, you saw that AE1, A3, which is a marker for epithelial differentiation, which comes in most of the carcinomas, that is also positive in germ cell tumors. So when there is a differential between a carcinoma and germ cell tumor, AE1, A3 is not going to help much. The marker which helps you is SAL4. SAL4 is a pan germ cell tumor marker, and that should be done because AE1, A3 and Glypican 3 both can come positive in hepatoblastoma as well as in yolk sac tumor. Next slide, please. See, and yolk sac tumor, there is this characteristic feature which we all know about is that Schiller dual bodies, but these are seen on only 50% of the yolk sac tumors. But when seen, it is very pathognomonic of yolk sac tumor. It is nothing but a central capillary vessel which is surrounded by columnar cells which are lying within a clear space, which is very characteristic of yolk sac. Yeah.
So post-surgery AFP subsided, and this is the last question. Dr. Jyoti, how do you stage and risk and further course of this patient?
So, this is a child who has an intra-abdominal mass and peritoneal deposits are positive. The omental deposits are positive for disease. So this would make it stage 3. So a child less than 2 years of age with stage 3 extragonadal tumor would be a standard risk 1 according to the MAGIC risk stratification. We should be able to get away with 4 cycles of JAB or 3 cycles with bleomycin, etoposide and cisplatin.
So because of omental deposits and muscle involvement.
Yes.
This patient was before MAGIC. So
Yes, that's fine, ma'am.
Okay, the last follow-up
Stage
was
3 extragonadal according to the COG would have been poor risk, and 6 cycles of BP is fine.
and follow-up child is doing well and AFP has been normalized. Last case, it's a 3-year-old with abdominal mass.
should we take last case?
Yes, yes.
Okay.
Just we'll finish my fast. 3 years abdominal mass. Next, just quick. So, yeah, this is a CT. Dr. Hiren?
Yeah, so what we are seeing here that there is markedly expansile mass lesion is seen in the left-sided suprarenal location. Epicenter is in suprarenal location. However, it has got some features that could say that it might be either infiltrating or arising from the left kidney. The left adrenal is not separately seen from the recent expansile mass lesion. It is pushing the stomach and the spleen anteriorly, and we can see that in the liver also there are multiple hypodense lesions are there which could be metastatic lesions. They are seen in the both lobes of liver, and the lesion also crosses the midline. It is displacing the aorta and IVC towards the right side. In the IVC, we can see that there is some sort of infiltration of the tumor inside the IVC. You can see that the tumor thrombus extending into the IVC at the renal hilal level. And posteriorly, you can see that. Can you just go lower down? Yeah, see here you can see that that it looks like more some kind of claw sign kind of thing, as if that it is arising from the kidney. So it's very difficult to say in such kind of tumors when they are markedly enlarged and occupying the left suprarenal and the retroparietal location, and when there is loss of fat planes and features of infiltration with the kidney, it's difficult to define whether it's arising from the kidney or it is secondary infiltrating. So in this kind of lesion, it's better to give both 2-3 differential. We can see that even there is enlarged adenopathy in the retroperitoneum in the aortocaval and the paracaval as well as para-iliac region. So based on that, I think we should give both differential. Either it's a tumor arising from the kidney like a Wilms, or we can give differentials of neuroblastoma or germ cell tumor also in this case.
Okay, thank you. Next slide, please.
So we have this pathology slide. Dr. Prasanna, I'm on. I think
No.
Okay.
We can't see.
This thing is not moving actually because of the scan. So it is directly coming here. So actually it is directly coming here. So this patient was actually thought of having a renal tumor, and they started with the Wilms tumor protocol, and they also did a biopsy. So this is the biopsy report which has come. I'm sorry, Dr. Prasanna, I think it is not moving from my side.
Yeah,
Because of the video. Dr. Anupriya, can you comment on this?
I can't see actually.
Okay.
Screen is frozen, yeah.
Is the screen sharing or is this coming now?
Patient has received chemo or
Hello.
hello? Yeah.
Yeah. Can you see, ma'am? Can you see?
Yeah. I can just
Yes. You can.
yeah, the IHC is positive for pancytokeratin and glypican is not expressed. PAC8 has been done to rule out a renal origin, and carbonic anhydrase 9 is also to rule out renal. And yeah, but they have not done anything specific for a germ cell, yet they are called it as yolk sac tumor. Okay. It was the tumor markers elevated also in this patient?
Yeah.
See,
Yes, ma'am. AFP was elevated, ma'am.
AFP was elevated. Okay, fine. So that's why, I mean, they concluded it as yolk sac tumor, but nothing specific for yolk sac. Like Lipicin 3 usually is positive, which is not expressed in this particular biopsy.
Okay,
So
this cyclin D1 and all suggestive of what?
cyclin D1, I haven't ever seen being done. I don't know the utility of cyclin D1 in this case. Yeah.
Fine. So as we know that AFP was grossly elevated to 55,000, then it reduced to 32, and the patient received the protocol, JEB protocol chemotherapy, and then followed by next week, followed by surgery was done. So, yeah, this is a post-chemo CT. So Hiren, can you go through that?
Yeah, so the post-chemo, we can see that there is significant shrinkage of the tumor, and now we are seeing some residual hypoenhancing necrotic mass in the suprarenal location. Of course, it has now still has lots of fat planes with the left kidney upper pole. The liver lesions, the liver lesions are still there. We can see some sort of hypodense lesions within the liver, so they are not completely disappeared. But in the IVC, we could not see residual tumor thrombus. It was looking like now IVC is more of a flattened and doesn't show any evidence of tumor thrombus. But the hypodense tumor was seen to involve the left renal vein in the initial scan, and we can see that near the left renal hilum vein, till that level we could see that still there is some sort of filling defect. So right now, what we're saying that IVC is not involved with the tumor, but still the left renal vein might be involved with the this kind of tumor.
Yeah, so it was very close to the tumor. Maybe renal vein may be involved.
Yeah.
Is it a little better that renal kidney is little free from the tumor? Is it still?
Yeah. So now we can see that now the kidney parenchyma cortex we are able to see. Previously, we were not able to see the renal cortex as confidently that we are seeing in this scan.
Okay. It could be still as a retroperitoneal, or it could be from the adrenal. Not this two.
Pardon?
Is it could be retroperitoneal or it's from the adrenal?
No, that is difficult to say since we are not separately seeing the adrenal, so we cannot. Yeah.
Okay, this child underwent excision, left adrenal tumor about 16 to 7 centimeter adherent to the upper pole of left kidney, and the tumor was also added to the pancreas at the junction, which they could be saved. The renal vein thrombus was present and the renal aorta is encased, so no other deposits. Renal vein was open and the tumor was excised in this patient. This is an excised gross tumor. Ma'am?
Yeah, this is the low power view which we are seeing, and what I can see is just tumor response. There is no viable tumor in this. All this pink thing which you see in the background, this is all stromal hyalinization and necrosis, along with these blue looking cells. Those are all inflammatory infiltrate. So this does not have any viable tumor. Yeah.
Next.
Yeah. So should I
talk
about? Yeah. So before I move to microscopy, there are a few things which I like to see, which I like to take care of, and that is I should know the age, the serum tumor markers, and gross examination of tumor is a must. And there should be adequate formalin fixation. Since the audience is mostly clinicians, I just want to emphasize on the fact that formalin fixation is very, very crucial for examination or further histopathological examination, because if the fixation is not good, then there is shrinkage of cytoplasm, and these germ cell tumors can then mimic any tumor. It can mimic a lymphoma and it can lead to an erroneous diagnosis. So formalin fixation in 10% neutral buffered formalin is mandatory. Next slide, please.
Yes.
And while looking at the slide, there are a few things which I see, and that is the growth pattern. Because these germ cell tumors are known for their different morphological patterns, that helps us to delineate whether it is seminomatous versus non-seminomatous. And then the cell type, whether they are uniform cells or they are pleomorphic bizarre cells, that also helps to delineate between the two. Then the nuclear features and mitosis also helps. And we have immunohistochemical armamentarium, which helps us to further delineate the diagnosis. And since you mentioned that you wanted to know about the IHC markers, so I prepared one slide for that. It's in the next slide. Yeah. So you see SAL4 is a pan germ cell marker. So if you are suspecting a germ cell tumor, then better to put a SAL4, because SAL4 will pick up all of the germ cell tumors, whether be it seminoma, embryonal carcinoma, yolk sac, choreo, teratoma, everything. So SAL4 is of very big help. And then you must also take notice that the pan-cytokeratin, which is positive in the epithelial tumors, in all your carcinomas, it also comes in all the germ cell tumors. So one must be very careful when interpreting a pan-cytokeratin as positive. It could be a germ cell or it could be a carcinoma. And coming to the specific markers, OCT34 is very helpful to delineate seminoma, and it also comes in embryonal carcinoma. For seminoma, we have a very specific marker, CD117. For embryonal carcinoma, CD30. And Glypican-3 comes in yolk sac tumor, also in choriocarcinoma, and beta HCG in choriocarcinoma. So it's essentially morphology and then a panel depending on the morphological differentials. So that helps in putting up the diagnosis. Yeah.
So specific markers are used depending on the
yeah, since see, if it is a teratoma, I don't need any marker. Teratoma will show me all the specific specific tissue related to all the germ cells like ectoderm, mesoderm, and endoderm. So I don't need a marker for teratoma. So it's just redundant to use any markers. But then there are certain which like embryonal carcinoma and choriocarcinoma. If it is a very small tissue, scanty tissue, I'm not able to delineate, maybe then I can put a CD30 or a beta HCG and then it will help me confirm. So it's not that every time markers are required, because morphology plays the key role. And depending on the situation, we add the panel. Yeah.
Thank you, ma'am. Okay, thanks, and everyone. It's very nice, and don't try to took a lot of time. I'm sorry for that. The sessions were good and the discussion was good. I hope everybody enjoyed and liked it. Thank you, especially for Pablo sir, who all the way taking the session. Any questions specifically which we missed and want to know? Anything?
Dr. Prasanna would like to have a photograph also in the end if possible.
Okay.
With the cameras on, screenshot please. Thank you, Dr. Pablo. I think Dr. Sushmita ma'am has already left. Dr. Hiren, Dr. Anupurva, and Dr. Jyoti. Thanks a lot.
Thank you. Thank you so much.
Thank you.
Can
the,
Dr. Prasanna help with the screenshot? Yeah. Requesting everyone to just switch on their cameras.
Jyoti?
I'm on my mobile, so I won't be able to see.
We can't see video.
Thank you. Bye all.
Thank you, everyone. Thank you, everyone, once again.
Thank you everyone for sharing your valuable insights. I hope you had a seamless experience and we are looking forward to host you again very soon. Thank you everyone.
Thank you.
So with all your permission, we are signing off for today.